In the following course and the following lectures, we will talk about a very complicated topic from my point of view. We will talk about diastolic dysfunction. There are many measurements to understand, and diastole is rather complex, so we will discuss what diastole and diastolic function is all about. Well, diastolic dysfunction is the combination of inadequate filling and relaxation of the left ventricle, reduced LF function, and the therefore resulting elevated filling pressures of the left ventricle. Overall, in diastolic dysfunction, why should we measure diastolic dysfunction? Well, in case of heart failure, the so-called heart failure with preserved ejection fraction, diastolic dysfunction and the stiff hearts play an essential role. Furthermore, it can be responsible for dyspnea, so patients with diastolic dysfunction can be symptomatic. You can find peripheral edema. It gives a lot of information about the prognosis of the patient, and we have to always think that patients with diastolic dysfunction might have a reduced exercise capacity. To summarize, the older the people get, the older our patients get, the stiffer the hearts are and the more severe diastolic dysfunction will be. Per definition, I already mentioned it, we have normally stiff, small hearts, or at least small cavities of the left ventricle. We can see a systolic dysfunction, so every patient with a systolic dysfunction must have a diastolic dysfunction, or there can be simply atrial dysfunction, and all those factors contribute to elevated filling pressures of the left ventricle. It's very important, and never forget that every systolic dysfunction is associated with a diastolic dysfunction. Then it's a matter of grading left ventricular filling pressures. And of course, diastolic dysfunction is often associated with reduced longitudinal dysfunction of the left ventricle, not necessarily with a reduced ejection fraction. Here I brought you a nice graphic where you can see that global longitudinal function measured by strain imaging is reduced in heart failure patients with preserved ejection fraction. You can see here all the values from -31 to 0, and in the range of -18 to -22, -23, that is a normal global longitudinal strain. In between -16 to -18, the little bit darker area, this is borderline, so could be reduced longitudinal function of the left ventricle, and below 16 is definitely pathological. And what we can see here most is that many patients with heart failure in preserved ejection fraction, so the dark blue columns, they have a reduced global longitudinal strain. Now is the question, why should we measure diastolic dysfunction? Well, it's important for monitoring patients, also for understanding the individual prognosis of a patient. Just imagine a patient with severe diastolic dysfunction will have more dyspnea, more hospitalizations, and of course a worse prognosis compared to a patient with normal left ventricular filling pressures. And sometimes diastolic dysfunction can point us towards another underlying cause of the possible diseases this patient might have. What is pathological? What is normal? There are two measurements or two pressures we have to remember. That's first the PCWP. That's the pulmonary capillary wedge pressure. Above 12 millimeters of mercury, it's pathological. And the left ventricular and diastolic pressure, which is normal below the value of 16 millimeters of mercury. So keep those two numbers in mind, because those are the numbers we have to remember if we talk about elevated filling pressures. Before we start to perform echocardiographic measurements, we have to understand the hemodynamics. In case of hemodynamics, first of all, there will be an elevated left atrial pressure. The left atrium is a low pressure system, so if the pressures in the left atrium will rise, it will lead to furthermore a pulmonary hypertension. So elevated left atrial pressures lead to pulmonary hypertension, and in case of pulmonary hypertension, we will have right ventricular dysfunction and dyspnea in the sequel of pulmonary hypertension. And when we have right ventricular dysfunction, probably right ventricular dilatation, a dyspneic patient, Also, tricuspid regurgitation will be more severe compared to a normal functioning right ventricle. To summarize this first lecture, let's have a look at possible causes of diastolic dysfunction. It's not only the hypertensive heart disease where you might think about diastolic dysfunction, but of course it's an important factor, so hypertension and cardiac remodeling, but also obesity, diabetes, elderly patients, as mentioned before, so aging population, heart failure with reduced ejection fraction and heart failure with mildly reduced ejection fraction have diastolic dysfunction. Patients with dilated cardiomyopathy, hypertrophic cardiomyopathy, and restrictive cardiomyopathy might have diastolic dysfunction. Patients with coronary artery disease, valvular heart disease, and left bundle branch block or pacing can show signs and symptoms of diastolic dysfunction. Well, now we have to continue and understand what diastole actually is. Here you see an ECG, and there's the P wave, the QRS complex, the T wave, and the next P wave and next QRS complex. And from the middle of the T wave to the P wave, this is diastole. How does diastole not only look in the ECG, but how does it look on the echocardiogram? In this case, you see a parasternal long axis view of the left ventricle. So it's focus on the left ventricle. You can see it in the middle. You see on top of the image the right ventricle, and you see the aortic valve, the mitral valve, and the left atrium. And the diastole is the time from AV closure until mitral valve closure. So when systole is done and the aortic valve closes, we wait for the opening of the mitral valve and then for the mitral valve to close again. This is the filling of the ventricle, so diastole. We can see it in another diagram, and in this diagram you will find several time intervals and waves we have to measure in a later stage. We see the E wave and the A wave over here. Then we see the IVRT and the IVCT and diastasis. What does this mean and how can we differentiate those time intervals? Well, let's start with the so-called IVRT. It's isovolumic relaxation time. It's a very, very short time interval from directly the aortic valve closure to mitral valve opening. So the mitral valve is not immediately opening after aortic valve closure, but there's a little bit of a time gap. That's the IVRT. Why is it called IVRT? It's in the name, it's isovolumic, so there are no volume changes within the ventricle. It's a relaxed ventricle with no volume changes because the valves are closed, volume cannot move. And the LV pressure is still below the left atrial pressure, and that at some point leads to the opening of the mitral valve. We continue with the rapid early filling. That's the so-called E wave. The rapid early filling phase, the mitral valve opens and the ventricle starts expanding. And LA volumes and pressures will drop, of course, and the LV literally sucks in all of the blood it can get. And this is approximately in young healthy individuals 70 to even 80% of the blood. The next phase that follows in between the E wave and the A wave is the so-called diastasis. The diastasis is also a short time interval where only little filling of the LV happens because the LV already sucked in all the blood it could get. It's very heart rate dependent, so in tachycardia you might not have this time interval, and the pressures in between the left atrium and the left ventricle, they are equalized. Then after the diastasis we have another phase, the so-called A wave. The A wave is the atrial contraction phase. Now the atrium contributes to the filling of the left ventricle, and in young healthy individuals it's approximately 20 to 30% of the blood which is pushed from the left atrium into the left ventricle. The left atrial pressures increase just a little bit to push the blood into the left ventricle, and at some point the left ventricular pressures are higher than the left atrial pressures, and then diastole is finished and the mitral valve is closing. The next time interval is the IVCT. The IVCT is the isovolumic contraction time, and this is the time already where systole starts. So the IVCT already belongs to systole. Let's review. Diastole is the time from aortic valve closure until mitral valve closure. So we are talking about this specific time interval, which is called diastole, so the filling of the heart. And the filling of the left ventricle is dependent on several factors. One of the factors is left atrial volume. On the right hand side, you can see a loop where you see that left atrial volume is increased. It's 95 milliliters. You have two possibilities to measure it. You can measure it as, in this case, without indexing on the body surface area. Overall, you should index it. Then you will also calculate an increased volume. So left atrial volume in diastolic dysfunction and left ventricular filling is an important factor. The second factor, which is important, is left ventricular suction. As discussed in the previous lecture, the expanding of the left ventricle, so the suction, is an active movement of the left ventricle, and it contributes to a very large portion of left ventricular filling. Another very important factor of LV filling is pressures in the left atrium, or elevation in the pressures in the left atrium, and the pressures of the left ventricle. And last but not least, another very important factor, you can see on the right hand side the strain image of a hypertrophied heart or a thickened myocardium, is the stiffness of the left ventricle. The stiffer the left ventricle becomes, the more increased are the filling pressures. And one more thing not to forget is the contractile function of the left atrium. The left atrium has several functions. You can see it in the graphic on the right side. There's a reservoir function, a conduit function, and the pump function. And the pump function is the A wave we discussed previously, which resembles the contractile function of the left atrium. Keep in mind that left atrial strain will be very important in the next lectures, and try to remember already the normal values for the two measurements we have in left atrial strain, the pulse, the peak atrial longitudinal strain, and the PAX, the peak atrial contraction strain, seen below the graphic. To see a normal example, we can visualize it in this image or in this loop. You see the left ventricle is normal in size, has a normal ejection fraction. The left atrium is also normal in size. We see that the overall volume is 35 milliliters, so with a body surface area of 1.7, 1.8, this of course is a normal value. And on the right hand side, we see the left atrial strain. We see the contraction strain or the contraction phase at the end, where we have the so-called PAX we could measure here, which has a normal value of approximately 17. This concludes the important parts of left ventricular filling. Let's move on to a brief summary about all the measurements we can have in diastolic dysfunction. I want to start this summary by telling you that left ventricular pressures overall cannot be exactly evaluated by echocardiography. Why is that? All parameters we have at hand have several limitations. We have to be aware to know these limitations to avoid pitfalls, of course. To talk about the parameters, the first we have to measure is the so-called E to A ratio. We have a E wave, the active filling of the left ventricle. You can see it as the first or the higher peak of the two peaks we see in the pulsed wave Doppler signal on the right side. And we have an A wave. If the E and the A wave don't ring a bell yet, maybe you want to click the box on the right up there to go back to a lecture where the E and the A wave are explained properly. In case of the E to A ratio, we see that this is a pulsed wave Doppler technique. It is very dependent on the insonation, so it's very dependent on the angle of insonation. It's dependent on image quality, of course, and there are limitations. For example, in case of atrial fibrillation, so AFib, we only have the so-called E wave or the peak E velocity and the deceleration time, which I will talk later about at hand, because in atrial fibrillation, the atrial contraction is lost. So we do not have an A wave. In tachycardia, sometimes it's hard to differentiate the E from the A wave. And another limitation is aortic regurgitation. In aortic regurgitation, sometimes you do not get proper signals and the signal of AR is interfering. What do I mean by that? Well, in aortic regurgitation, as seen in this apical long axis view, you see that the color Doppler signal is interfering with the mitral valve inflow signal. So aortic regurgitation can interfere with your inflow signal, so you have to be very careful what you measure and where you put the pulsed wave Doppler. In atrial fibrillation, as seen in the example on the right side, you have several peak E waves or E waves, but you do not see an A wave. So you have to take a measurement, which is a mean measurement of several cycles of the heart. To continue with the summary, we said all parameters do have several limitations. We discussed now E to A ratio, but what about E to E prime? Well, also E to E prime is a Doppler measurement, so it's again dependent of the angle. It uses the tissue Doppler technique. The tissue Doppler measures the velocities of tissues, not of blood flow. It is also dependent on the image quality. Mitral annular calcification is a huge pitfall. Also operations on the mitral valve, for example, mitral valve replacement or annuloplasty, and of course wall motion abnormalities. In case of an inferior infarct, you might have wall motion abnormality in the basal septum, and when you have a wall motion abnormality, of course, tissue Doppler measurements will not be accurate. Here's an example of a patient with a mitral valve replacement. You see a turbulent jet, a turbulent inflow, and in this case you cannot properly measure an E to E prime ratio. And in atrial fibrillation, well, if you can measure an average, E to E prime can be applied. But be aware, you really have to measure an average and not the highest E you can find or the lowest E you can find and the highest E prime and lowest E prime, but really try to average several heartbeats to be able to measure a proper E to E prime ratio. In case of the left atrium, image quality is tremendously important, and very often I found case studies or studies where simply the left atrium was not fully displayed. So always be aware that you see or visualize the entire left atrium. Also in this case, the ceiling of the left atrium is not entirely seen, so I also am not too happy with this view on the right side. And another signal or another measurement we have to perform is the measurement of the tricuspid regurgitation. In case of tricuspid regurgitation, it's tremendously important to have an optimal image quality and an optimal signal quality, as in this case. If you do not have an optimal signal quality, you simply do not know what you measure. So keep that in mind if you measure the tricuspid regurgitation signal. We started with a summary of diastolic dysfunction, and we discussed the parameters you need to assess diastolic dysfunction. And all those parameters do have limitations. But there are also some situations where the measurements cannot be applied. And one of these specific situations is relevant mitral regurgitation. Here I provided you with a loop with relevant MR, and in this case, you simply cannot assess left ventricular filling pressures properly. So if you see relevant MR, so it's not talking about mild or mild to moderate mitral regurgitation, but moderate to severe or severe mitral regurgitation, you shouldn't apply measurements for diastolic dysfunction. The next situation you have to be aware of is heart transplant. In heart transplant patients, you also shouldn't measure diastolic dysfunction, especially at the early stages when heart transplant is not too long ago. The measurements will be entirely off, but there's one measurement you can actually do, and that's the tricuspid regurgitation and the systolic pulmonary arterial pressure. If you have a proper TR signal as seen in the right side, so the image is a bit turned around, it's an atypical apical view of the right ventricle, and you see TR. When you have that, you can measure TR and the peak velocity and therefore calculate systolic pulmonary arterial pressures. The next situation you cannot apply the measurements is in patients with a left ventricular assist device. How do you know that there is a left ventricular assist device present? Well, left ventricular assist devices are used in heart failure patients. In this case, you see a short axis view of the subcostal approach of the heart. If you want to know how to perform subcostal views, not only the 4-chamber view, in the compact echo course you will find videos about the subcostal approach and all other views of the heart as well. Well, in this specific view, you see that there is in the center of the heart a structure which doesn't belong there. On the right hand side, you have the same patient in a parasternal long axis view. You can see the left ventricle, the mitral valve, the right ventricle, and in the center of the left ventricle, there is this assist device. So be aware that in this case, with a left ventricular assist device, you cannot measure diastolic dysfunction. And of course, we mentioned it already, in atrial fibrillation, you have several limitations. For example, that you do not have an E to A ratio, but you can rely on E to E prime. And E to E prime in atrial fibrillation actually provides a lot of information, because E to E prime increases with severity of heart failure in those patients. So an actual E to E prime which is lower is better, and an E to E prime ratio is overall better than BNP and left atrial area. And if an improvement of heart failure with, for example, heart failure treatment is possible in a patient, E to E prime is declining. Continuing, we do have several formulas to provide us with calculations of left ventricular filling pressures or the pulmonary capillary wedge pressure. But be aware, those formulas are far away from being exact. Sometimes they could be helpful, so I want to list some formulas you can use. The first one is the calculation of the PCWP, the pulmonary capillary wedge pressure. It's simply E to E prime plus 4. That is very often used, for example, in emergency departments to get an overview if an increase in pulmonary capillary wedge pressure is present. Another formula is the so-called Naguet formula, which is 1.24 times E to E prime plus 1.9 equals the pulmonary capillary wedge pressure. You see that this formula is already rather complicated, so you have to be aware that you really have to measure exact, and that there are also limitations in the actual measurements you can acquire. Another possible formula is the E divided by the velocity propagation. Then you can calculate the left ventricular and diastolic pressure. And if this E to velocity propagation ratio is above 2.5, the left ventricular and diastolic pressures are above 15 millimeters of mercury in patients with reduced ejection fraction. So also a measurement with several limitations, and you will see an example of this velocity propagation. It's per se a very complicated measurement to perform. There's another measurement where you can include the velocity propagation and the IVRT. It's 4.5 times 10 divided by 2 times the IVRT plus the velocity propagation minus 9, and then you get the left ventricular and diastolic pressure. Please see all the brackets as they are written in the formula, but also in this formula you see there are many variables, and especially the IVRT and the velocity propagation I consider very hard measurements. So simply be aware that all these formulas have several limitations and pitfalls. But if you're curious and you want to try those formulas, I encourage you to try it. It is, if you have the time to do it, actually a lot of fun. And combine it or compare it with the invasive measurements if you have a possibility to measure it invasively. Moving on, I want to introduce the term indeterminate. The indeterminate patients of left ventricular filling pressure, so diastolic dysfunction, was introduced in the 2016 guidelines of the Societies of Echocardiography, where there was a differentiation in healthy left ventricles and sick left ventricles and the resulting diastolic dysfunction. Now let's have a look at the first graph of these guidelines. You see now that patients with normal left ventricular function or normal left ventricular ejection fraction have several parameters you have to acquire to determine if they have a normal diastolic dysfunction or a diastolic dysfunction, or if it is indeterminate, which simply means we do not know. You have the average E to E prime ratio, you have the septal E prime velocity and the lateral E prime velocity, or one of them. you have the TR velocity and the left atrial volume index. If more than 2, so more than 50% are positive, you can say that patients with normal left ventricular ejection fraction have diastolic dysfunction. If only 1 is positive and 3 are negative, so for example, the average E to E prime velocity is 16, but the lateral E prime velocity is 11, the TR velocity is 2.6, and the LA volume index is 30 milliliters per square meter, you have a normal diastolic function. And if 2 are positive and 2 are negative, it is indeterminate. Now we take an example where you can use the first chart we have seen in healthy left ventricles. This is a normal left ventricle with normal systolic function, so normal ejection fraction. It might be in the range of 55 to 60%. You do see that this must be a relatively young patient. The valves, the mitral valve and the tricuspid valve, they look normal. You see that the walls of the heart are not thickened. There are no regional wall motion abnormalities, and there is no left ventricular dilatation. Well, it is different now in patients who have sick left ventricles. Then the column of how you interpret diastolic dysfunction even becomes more complicated. So first of all, we have to see the mitral inflow. If you see the mitral inflow, you always have an E to A ratio, and depending on how this E to A ratio is, you go either to the left side or to the right side, or you stick to the middle. We will go into detail of this chart soon, but overall keep in mind that there is a diastolic dysfunction grade 1, where you can say that the left atrial filling pressures are normal. The diastolic dysfunction grade 3, where the filling pressures are definitely elevated, and that there are 2 more differentiations. The patients we simply cannot determine, so we do not know if their filling pressures are elevated or not, and the grade 2 diastolic dysfunction, where we also can assume that filling pressures are elevated. Before we dig deeper into this topic, I want to show you possibilities when the left ventricle is sick. Here I have several examples. The first one on the left-hand side, you can see that there is a regional problem. The apical regions, there's a wall motion abnormality. This is a patient with an infarct, so an LAD problem, and of course in reduced ejection fraction, and this patient has a reduction in ejection fraction even though the basal segments are even a bit hypercontractile. We have diastolic dysfunction. On the right hand side in this slide, we do see another possibility where we have probably normal left ventricular ejection fraction, but we have to determine filling pressures. Also in this case, the left ventricle is sick, so the diastolic function cannot be normal, but there has to be diastolic dysfunction. We just have to figure out if the filling pressures are elevated or if they are not elevated. More examples of sick left ventricles are seen in this case. You have here a dilated left ventricle. You also see a dilated left atrium. You see a reduction in opening of the mitral valve, and definitely a reduction in left ventricular function. You do see wall motion abnormalities of the septal region and the apical regions. On the right hand side, you have another example of a definitely sick left ventricle. This is a patient with amyloidosis, amyloid heart disease. You see a reduction in left ventricular ejection fraction, but you also see that the myocardium is significantly thickened. Also the left atrium, if you take a look at the left atrium, it's also dilated. In the previous lecture, we talked about the 2016 guidelines on diastolic dysfunction, and now we continue with all the specific situations you might encounter when you assess filling pressures. Well, the first situation, and this is the situation you always have to find, is the so-called diastolic dysfunction grade 3 with definitely elevated filling pressures, or the restrictive filling. This specific case, you measure first the E to A ratio, and if it is 2 or above 2, we have grade 3 diastolic dysfunction. But be aware, this is the case in sick left ventricles. If you have a young healthy individual or someone who does a lot of sports, the E to A ratio can be above 2, which simply is supranormal because the heart is not stiff but very elastic. In the case of restrictive filling, the heart or the left ventricle is very stiff and the filling pressures are definitely elevated. How does it look like in a patient case? Here you have a case of a patient with a restrictive filling. The E to A ratio is definitely above 2, which equals elevated filling pressures. When we think about how diastole looks like in case of the measurements of the pulse wave Doppler we take, we have to see that the E wave is way larger than the A wave, and if the ratio is above 2 or 2, we have diastolic dysfunction grade 3 restrictive filling. The next steps, they are not really mandatory, but if you want to prove that this is really restrictive filling and significantly elevated filling pressures, you have to measure the E to E prime. It's not mandatory, but it has to be significantly elevated. So a situation where you have this E to A ratio above 2 or 2 and you have an E to E prime of 6, for example, that cannot be a restrictive filling. So always keep in mind to prove what you measure. The next situation you have to know is the diastolic dysfunction grade 2. In this case, we also have elevated filling pressures, but we do have a more complex tree we have to follow. We have to start again with the mitral valve inflow. We have to have an E to A ratio above 0.8 until below 2, so 1.9. And the second situation, which can be, is a E to A ratio below or 0.8, but an E wave of above 50 centimeters per second. After that, we have 3 criteria we have to evaluate. Those 3 criteria are the average E to E prime ratio. So we have to measure the maximal E velocity, the maximal E prime velocity, medial, lateral, so septal and lateral, and combine those 2 measurements, calculate the mean average E to E prime. TR velocity we have to measure. If it is above 2.8 meters per second, it is considered as pathological, and we have to have a left atrial volume index above 34 milliliters per square meter. So here it is specifically noted that you have to measure the indexed volume of the left atrium. And in case if you have these 3 criteria and if 2 of the 3 criteria are positive, this is definitely diastolic dysfunction grade 2. If you only can measure 2 criteria out of 3, for example, the average E to E prime and the left volume index, and both are positive, this still is sufficient. It's then again diastolic dysfunction grade 2. If you can measure all 3 and all 3 are positive, but we do not have a restrictive filling, still it's the diastolic dysfunction grade 2. Now we have to see how to measure a tricuspid regurgitation. In the 4-chamber view, we can measure it. We have to use color Doppler, and with the guidance of color Doppler, we can measure the peak signal of the tricuspid regurgitation seen on the right-hand side with continuous wave Doppler. This is approximately 3.1 meters per second, so definitely above 2.8 meters per second, which favors or equals an elevation in pulmonary arterial pressure, the systolic pulmonary arterial pressure, and is a positive marker for diastolic dysfunction. If you cannot measure it in a 4-chamber view with a focused view of the right ventricle, which is seen here on the left side, you can also simply move an intercostal space more cranially. Very often in a more cranial approach, you have a better angulation towards the TR signal. Simply try it. If you have a normal focused right ventricular 4-chamber view and you cannot measure TR signal, move one intercostal space more cranially and you will see nicely the TR and how you can measure it. If that is also not possible, you can go to a right ventricular inflow outflow view. That's an apical view or an apical 2-chamber view of the right ventricle. How to acquire these views you will learn in the compact echo course, so check it out as soon as they are online. But how is it? Does it really work, and can we measure every time the same velocity? Well, the image quality has to be sufficient. Another possibility how to measure TR is the peristernal short axis view with a tricuspid valve focus. So you go to the peristernal short axis view, focus on the tricuspid valve, and use the continuous wave Doppler. And what we can see here is that the signal is not optimal, but we see it is far exceeding the 2.8 meters per second. It's in the range of 3.5 to 4 meters per second in this measurement. If this also doesn't work, you can acquire another view. It's the peristernal long axis view. In the peristernal long axis view, you simply tilt down the transducer towards the right ventricle, and then you see the tricuspid regurgitation angulated optimally. Sometimes this is the best view to acquire an optimal signal. And if you now use continuous wave Doppler, you again see that the signal exceeds 2.8 meters per second, and it is also in the range of 3.5 to 4 meters per second. Try it in all the views and compare your measurements to get the most exact towards what the true peak measurement of the tricuspid regurgitation is. This, of course, is important to evaluate the systolic pulmonary arterial pressure correctly. To move on to the next measurement, we have to understand how to perform the tissue Doppler imaging of the mitral valve annulus. You have two positions. You have to place the pulsed wave Doppler, the TDI, with the pulsed wave Doppler inside. It's the septal and the lateral mitral valve annulus. On the left-hand side, you see the septal mitral valve annulus. You see that there are two waves downwards. This is the E' and the A'. The movement towards the loop is the S'. But we focus now on the E'. The E' in this case is the smaller wave. It's below 6 or 7 centimeters per second at the septal mitral valve annulus. If we focus on the lateral mitral valve annulus, we also see that the E' wave is definitely reduced. It's not above 10 centimeters per second. You see the velocities on the very right side of both images. And you also can appreciate that this is a reduced TDI measurement of the lateral and the medial mitral valve annulus. To combine this or to put it into a measurement, we also can use for sick left ventricles. We have to calculate the E to E'. So we take the E wave and the E' wave of the septal and the lateral mitral valve annulus, and we calculate simply the ratio. There are some tips and tricks you have to remember when it is about tissue Doppler. The tissue Doppler simply measures tissue velocities. The velocities are not as high as, for example, the blood flow. So keep in mind that you really have to use the specific preset to use the tissue Doppler and then the pulsed wave Doppler. Set the sample volume in approximately between 6 to 8 millimeters. And another important tip of what you can use is that you tell the patient to exhale. If you place the sample volume and expiratory, you sometimes have better image quality. What are now the norm values? What do we have to know? What do we have to remember? Well, the E' septal is below 7 centimeters per second, then it's pathological. The E' lateral below 10 centimeters per second is pathological. And the ratio of the E wave and the E' wave is 14, so the cutoff is 14. Everything above 14 is abnormal or pathological. If you only can measure it, for example, in the septal region or the lateral region, the E to E' septal above 15 is pathological and lateral above 13. A lot of numbers to remember. Simply write them down and put them in your echo lab to not forget those important numbers. The next measurement we have to know and we have to perform is the so-called LAVI, the left atrial volume index. We already said that the pathological value is above 34 milliliters per square meter. The normal range is 16 to 34 milliliters per square meter. So always, in case of diastolic dysfunction and in case of your echo reports, calculate the body surface area and index the left atrial volume. Now it is time to continue with diastolic dysfunction grade 1, where you won't find elevated filling pressures. In this case, you have several situations. First of all, if two of the three criteria we discussed before, so the average E to E' above 14, the TR velocity above 2.8 meters per second, and the left atrial volume index above 34 milliliters per square meter are not fulfilled, it means you do have diastolic dysfunction grade 1 in case, and now we have to move up to the E to A ratio of the mitral valve inflow, an E to A ratio above 0.8 until below 2. Remember, above 2 or 2 means restrictive filling pattern, so diastolic dysfunction grade 3. Or we have an E to A ratio below or 0.8 plus the maximal E velocity of 50 centimeters per second. So if you evaluate those three criteria and two are not fulfilled, you have diastolic dysfunction grade 1. Another case of diastolic dysfunction grade 1 in the mitral valve inflow would be an E to A below or 0.8 plus an E below or 50 centimeters per second. If you have this scenario, it's automatically diastolic dysfunction grade 1 in patients with a sick left ventricle, sick left heart. Let's take a look at an example. You see it over here. We have here an E to A ratio of below 0.8 or 0.8. In this case, the maximal E velocity, which is the first of those two curves, so the lower curve, is below 50 centimeters per second. You can see it here, it's just a little bit below 50 centimeters per second, and it's a rather small E wave and a rather large A wave. This is already diastolic dysfunction, grade 1. Overall, there are some more parameters you can distinguish or you can measure. It's the deceleration time, which is in the range of 140 to 240 milliseconds. Another thing you can measure is the isovolumic relaxation time, the IVRT, and it's in the range of 70 millimeters per second. Keep in mind that this is a rather difficult measurement, but you can try it if you want to and stick to those norm values. Another situation, when you see, for example, an L wave, it does mean that there are very likely elevated filling pressures, and you can also interpret the pulmonary vein flow signal. In this example, you have two more parameters or two more signs you can look at. If you see a dilated left atrial appendage as seen in the right side of the image and the right side of the slide, you see that the left atrial appendage on the very right side is dilated. Here you can see it, that points towards elevated filling pressures. And on the left hand side, you see the E to E prime ratio of this patient was 20, so definitely pathological. And in this case, you nicely see an L wave. The L wave is a wave in between the E and the A wave. Over here you can see quite nicely, this is the so-called L wave. In case you see an L wave, elevated filling pressures are very likely. To continue with the pulmonary vein flow signal, this is also a very complicated measurement. Sometimes you can measure several things. You can measure the AR to A duration above 30 milliseconds, the peak reversal flow, so the AR per se, and the reduction of S to D. And if that is 1, it's pathological. So what does this all mean, or how would you measure it in TE? It's quite often possible to measure it if you know how to do. In TTE, I would say it's often not possible. Very often it's just not easy to get those kind of measurements, to get this signal. You would delineate the apical 4 chamber view, and at the roof of the left atrium you see the pulmonary veins entering. In specific, it would be the right upper pulmonary vein where you would often get this signal, or most likely get this signal, but still it's very, very complex and you have to try several times, even in patients which are optimal to scan. How does it look like, or how does the mitral valve inflow signal and the pulmonary venous signal look like in the echocardiogram? You can see that the pressures on the left-hand side are normal. You see the normal E to A ratio. You have the IVRT at the beginning. You have the pulmonary venous flow signal. You have the systolic flow and the diastolic flow. And you have the mitral annular velocity, the E prime and the A prime. You can see that the isovolumic relaxation time over time in impaired relaxation, as it was called before the new guidelines, the pseudonormal or the restrictive filling pattern. So basically it's grade 3 diastolic dysfunction in a restrictive filling pattern, that the IVRT is becoming relatively short. The S to D ratio differs, so in healthy individuals you have a higher systolic versus the diastolic measurement, and the higher the filling pressures are, the lower the systolic measurement will get and the higher the diastolic measurement will get. And if you have an S to D ratio mentioned before of 1, it's considered pathological. Furthermore, you can see the AR time, so the reversal flow of the pulmonary venous signal. It becomes higher the more the filling pressures are elevated. But you can see in this diagram that all those measurements are very complex, and you really have to have nice signal to differentiate all those patterns. In the next image, I want to show you such a pulmonary venous flow signal. You have the systolic flow denoted with S, you have the diastolic flow denoted with D, and this AR time, and this is a normal situation. You have a normal systolic flow and normal diastolic flow. It's not one, so the diastolic flow is a little bit smaller than the systolic flow. This was a TE study, so this is not a TTE signal. So in TE, you can very often nicely delineate those signals. To compare this with a pathological example, on the left-hand side, you have the normal variant. You see nicely the AR time, the systolic and the diastolic flow. And on the right-hand side in the slide, you see that there is a flow reversal in severe mitral regurgitation. You have this signal, again, the systolic signal, which is way smaller than the diastolic signal, which denotes that it is pathological, and you have this flow reversal, the systolic flow reversal in severe mitral regurgitation in between the S and the D wave. Those are all signals from transesophageal echo, where you can mostly get a way better image compared to the transthoracic approach. To move on, we can also do a scoring for heart failure with preserved ejection fraction, where diastolic dysfunction plays an essential role. There are two scores I want to mention: the HFpEF score, the H2FPEF score, and the HFA-PEF score is the score you see on the right-hand side. In the image, there are major criteria and minor criteria. This is a two-step approach in diastolic dysfunction. You can check out this scientific paper. It's really a nice read. And in this step 2, you see that you have some functional criteria, some morphological criteria. Also, biomarkers are included in sinus rhythm and in atrial fibrillation, and you have the norm values. Denote that the minor criteria also include the global longitudinal strain already. The major criteria in functional assessment are the septal E prime, the lateral E prime, the average E to E prime, which is here above or 15, or the TR velocity. So it's assessment of heart failure with preserved ejection fraction. You have one major criteria, which equals 2 points. And if you add the morphological criteria, for example, the LAVI, so the left atrial volumetric index above 34 milliliters per square meter, which is also essential for assessing diastolic dysfunction, you can see that these are again major criteria for the diagnosis of heart failure with preserved ejection fraction. And then you would need an elevated biomarker, so the NT-proBNP or the BNP above certain levels to distinguish, is it really heart failure with preserved ejection fraction. If you, for example, do not have elevated biomarkers, you would need a diastolic stress test or invasive hemodynamic measurements. Now, if you perform this score, you see that the functional and morphological parts play a very important role. So echocardiography is essential in diagnosing heart failure with preserved ejection fraction. Now, there was the term diastolic stress test. Diastolic stress testing is like the left ventricular stress testing. You can check out also the literature here, but the most important thing is that you keep in mind that during the stress test, the E to E prime ratio has to be elevated above 14, and the TR velocity has to be above 2.8 meters per second during the stress test. Also, the hand grip stress test is quite nice when you see the E to E prime ratio is rising and the TR is rising. That points you towards that there's really a diastolic problem, so possibly a heart failure with preserved ejection fraction. If you combine those two measurements, the E to E prime and the TR velocity, the sensitivity and the specificity is not that bad. If you have only one measurement possible, so for example only the E to E prime, it's actually not that good. So keep diastolic stress testing in mind. If you cannot perform it, an invasive measurement would be more appropriate. Another measurement, which is rather difficult to do but important, and you can use it for several formulas, is the color M mode flow propagation. You can see it quite nicely over here. You have the mitral valve plane, and you have to measure from the mitral valve plane in color M mode 4 centimeters distally into the LV. Above 50 centimeters per second is considered normal. So if it's below 50 centimeters per second, there might be elevated filling pressures. As mentioned in the previous lecture, the velocity propagation can distinguish or calculate the pulmonary capillary wedge pressure. Keep in mind that this measurement also has several pitfalls, and it's sometimes very difficult to delineate the mitral valve inflow or also the mitral valve planes. To continue with the summary, we already said that all the parameters have several limitations. In some situations, some measurements cannot be applied. All the formulas I presented to you do have limitations, but still there is this term of the indeterminate. In the next video, we will talk more in detail about these specific situations in diastolic dysfunction. It is time now to move on to the specific situation if you find that diastolic dysfunction is indeterminate. What does it mean? How does it look like in the chart of the guidelines? Well, it's the situation when you have one criteria which is positive, one criteria which is negative, and you cannot measure the third criteria. So let's recall we have the mitral valve inflow, we have the situation where there's E to A ratio below or 0.8 plus the E maximal velocity above 50 centimeters per second, or simply the E to A ratio, which might be the most common situation, of above 0.8 but below 2. The three criteria we already discussed have to be evaluated. The average E to E prime above 14 is considered pathological. The TR velocity above 2.8 meters per second, which is pathological, and the left atrial volumetric index, so above 34 milliliters per square meter, it's considered pathological. And if you have only two of the three criteria present, for example, very often it will be that TR velocity is not accurately measurable. You have only two criteria, so the average E to E prime and the LA volume index. You have one positive and one negative. We simply do not know. In this situation, when you only have two available criteria, so for example, the average E to E prime above 14 or the LA volume index above 34 milliliters per square meter, and you cannot measure, which will be, I would say, mostly the case that you cannot accurately measure tricuspid regurgitation. You have only those criteria present, and if one is positive and one negative, for example, you have an E to E prime ratio of 10 and an LA volume index of 38 milliliters per square meter. You have one positive, one negative criteria. You're in the situation of indeterminate. So you do not know if diastolic dysfunction with elevated filling pressures is present or not. According to new literature, still we can measure left atrial strain. In left atrial strain, we have several phases and functions we have to differentiate. We have the reservoir function, you can see it here painted in red, the conduit function, and at the end the atrial contraction phase. So the reservoir function is the filling of the left atrium, it's the aortic valve opening until the aortic valve closure. Then it continues with the mitral valve opening until the mitral valve closure. So the conduit function is then the filling of the left ventricle, so pumping out the blood of the left atrium. Then there are several measurements we can have. So the first measurement is the pulse, the peak atrial longitudinal strain, and the second is the PAX, the peak atrial contraction strain. There are norm values. The first norm value for the pulse is around 39%, so it's a positive value, and the PAX is approximately 17%. It's also a positive value. If you measure those two and if you know those phases, you can help to identify also the situations where it might be indeterminate with the prior known markers. If you compare the LA strain with the ECG, you see that there's the QRS complex and the second QRS complex, the T wave and the P wave, and this is how it looks like. So at first we have the filling of the left atrium and then the filling of the left ventricle in diastole. Why would you measure this? Why would you measure LA strain in diastolic dysfunction? Well, the LA strain, if it's pathological, it's better than the left atrial volumetric index in regards of identifying if there's diastolic dysfunction really present. If you combine the measurements of left atrial strain and the left atrium volumetric index, you will have a better detection of diastolic dysfunction. If you have a pulse, a peak atrial longitudinal strain below 23%, it will show you that there are more hospitalizations in these patients, even double the amount of hospitalizations, and the patient will be more symptomatic. So the patient will experience more dyspnea. So the measurements of the pulse and the PAX, they are quite important, but also keep in mind to combine these measurements with the left atrial volumetric index. The better we measure, the more accurate we measure, the more better we get in the detection of actual diastolic dysfunction. If we talk now about diastolic dysfunction and the elevation of filling pressures, there's a nice paper where it was identified that the pulse, a peak atrial longitudinal strain below 18% is very likely to have a pulmonary capillary wedge pressure above 12 millimeters of mercury in situations of a reduced systolic function versus a preserved systolic function. So the ejection fraction was taken into account, and in a reduction of ejection fraction, this marker, the pulse below 18%, was quite good. In preserved ejection fraction, this marker alone was not perfect, but gives a hint towards elevated filling pressures. In a case where the pulse is even lower, below 16%, the pulmonary capillary wedge pressure is most likely to be above or 15 millimeters of mercury, so elevated. The PAX, the peak atrial contraction strain, was very good to identify normal filling pressure. So a PAX above 14% identifies normal filling pressure, so pulmonary capillary wedge pressure below or 12 millimeters of mercury quite accurately in a normal functioning left ventricle, so in a global longitudinal strain of above -18. The PAX below 8% was a quite good marker to denote elevated filling pressure. So if the peak atrial contraction strain is elevated, the filling pressures are elevated as well. Let's take a look at the patient. In this patient, we have a situation of apical hypertrophic cardiomyopathy. This patient was somewhat symptomatic, and now it was time to identify if there are elevated filling pressures likely. In this case, we do see two measurements. We see the pulse, which is approximately 28%, and the PAX, 13%, which denotes in this case likelihood that there are no elevated filling pressures. So combine the measurement of the pulse and the PAX, as we have noted in the previous slide, to identify if there are elevated filling pressures in sick ventricles. If we take a look at the next example, we also denote that there might not be elevated filling pressures. In this case, the peak atrial longitudinal strain is entirely normal, so it's 43%. The PAX of 18% is also entirely normal. So in this case, we are practically sure that there are no elevated filling pressures. This was a patient with coronary artery disease, and you can see the apical wall motion abnormality, but this patient was not symptomatic. We do know that filling pressures are not elevated. On the other hand, we have a patient with elevated filling pressures. You do see also a severely reduced left ventricular ejection fraction. The patient also had a severely reduced global longitudinal strain of LV strain imaging. We can identify initially that the curve entirely looks different compared to the previous images or the patients with most likely no elevated filling pressures. In this case, we have a severely reduced pulse of only 6% and we have a PAX of only 2%. There are definitely elevated filling pressures. So do use left atrial strain to be more sure about the evaluation of filling pressures. In diastolic dysfunction, it's very important to take the easier way. All the measurements are very complicated, but LA strain helps us to identify and reclassify the indeterminate situations in 99%. Be aware though, it is not a standalone parameter. You need all the other parameters we discussed. Overall, the left atrial strain is quite easy to do and it is reproducible. And also keep in mind that LA strain has limitations in atrial fibrillation. There you only can use the pulse, but of course not the PAX because the atrial contraction is missing. So the A wave is missing, also the PAX is missing in atrial fibrillation. In this first image, you have a patient with a reduction in basal strain, but overall a normal global longitudinal strain. The global strain, so the GS, is minus 20.5%. Overall, everything below minus 18, so minus 19, minus 20, minus 21, and so on is normal. Minus 16 to minus 18 is borderline, and below minus 16 is definitely an abnormal global longitudinal strain of the left ventricle. But why would we measure the LV strain in diastolic dysfunction? Well, in heart failure with reduced ejection fraction, it correlates with the natriuretic peptides, the BNP, also with the fibrosis of the heart, with survival, hospitalizations, and of course with diastolic dysfunction as well. So the lower the LV strain, the worse diastolic function will be, and elevated filling pressures are more likely. Furthermore, in heart failure with preserved ejection fraction, you will have a reduction in left ventricular strain in the early stages, especially of HFpEF, so the heart failure with preserved ejection fraction, where you have the good ejection fraction but the bad strain. So the cutoff here would be -15. So if below -15, the outcomes of the patient with heart failure with preserved ejection fraction is also worse. Let us try and evaluate a patient. We have here a patient with a thickened myocardium, but a normal left ventricular ejection fraction. We do see that ejection fraction is approximately 55%, so normal. If you take a look at the right ventricle, it's not dilated. So the main problem here, what we see is that the left ventricle has a thickened myocardium. Now we have to take a look at the LV strain. The global longitudinal strain is -15.1%. So it's very borderline to -15. The basal strain again is reduced, so reduction in strain are the lighter red colors. It's in between -11 in the inferior regions, whereas in the anterior and lateral regions it's approximately -5, -6. There is this so-called apical sparing. It is the sparing or the normal function of left ventricular strain of the longitudinal function of the left ventricle. In the apical regions you see normal values, so the darker red colors. In between red or reddish colors is just the gradient. So the basal segments, they have a reduced function. The apical segments do seem to work normally or have a normal longitudinal function. Now we have to assess diastolic dysfunction, and when we take a look at E to E prime, so the ratio on the left hand side you see the E prime septal. It's 6.5 centimeters per second, which is borderline, but actually normal. On the right-hand side, you see the E prime lateral, 8 centimeters per second, which is reduced. The E velocity is above 50 centimeters per second. So we do not automatically have a diastolic dysfunction grade 1, but we have to think more and continue our measurements. And in this case, the E to E prime ratio is below 14, so it's normal. Now let's take a look at the left atrium. As you can see already in the smaller parts or the smaller loops, the left atrium is definitely enlarged. You have a left atrial volume overall of 78 milliliters, which in this patient equals 41 milliliters per square meter. So it's definitely an enlarged left atrium. So we have now one negative criterion, the E to E prime ratio, but one positive criterion, the volumetric index. If we continue to TR was simply not possible to measure in this patient. Now we have the situation where the mitral valve inflow signal did show an E of above 50 centimeters, even though the E to E ratio was below 0.8. We evaluated the three criteria, but we only had the E to E prime ratio, which is below 14, namely 8.5, but we did have the left atrium volume index above 34 milliliters per square meter. It was 41 milliliters per square meter, so definitely pathological. So now it is indeterminate. We do not know if filling pressures are elevated. We do not know if it is diastolic dysfunction grade 1 with normal filling pressures or diastolic dysfunction grade 2 with likely elevated filling pressures. As we have discussed previously, we can use left atrial strain and left atrial function. We have to look at two measurements, the pulse, the peak atrial longitudinal strain, and the PAX, the peak atrial contraction strain. If we do that and apply those measurements, you already probably have seen it before, we have a pulse. I simply can see it over here as well. At the tip of the curve, the pulse is approximately 30%, so that's reduced but points us towards normal filling pressures. And the PAX is 19%, so it also points towards normal filling pressures. If we take a look at the slide we have seen before, the diastolic dysfunction in case of a pulse below 18% or below 16% might show elevated filling pressures, also in patients with a preserved ejection fraction, and the PAX below 8% denotes elevated filling pressures. In this case, we have a pulse way above 18% and the PAX definitely above 14%, and the PAX above 14% in patients with a normal left ventricular function, or in this case a global longitudinal strain of -18, identifies normal filling pressure. Still, we know that the global longitudinal strain was reduced, the ejection fraction was normal, but if you look at all those measurements and if you combine it, we are relatively sure that in this case the filling pressures might be normal. As you can see in this example, The diastolic dysfunction is a puzzle, and we have to put together all the puzzle pieces, and left atrial strain, with the knowledge we have from the literature currently existing, can help us to identify normal filling pressures. Also in patients with a reduced global longitudinal strain, but with a preserved ejection fraction. Still, the more values we have to keep in mind, the more complicated it will be. In this situation, it was a rather special situation, but still, with the help of left atrial strain, even though global longitudinal strain is reduced, we can be quite sure that filling pressures are normal with the measurements of the peak atrial strain and the peak atrial contraction strain. To continue the summary, in the next lecture we will discuss the therapy of heart failure with preserved ejection fraction. As we know now how to deal with an indeterminate situation and that left atrial strain really can help us, we have to discuss the heart failure with preserved ejection fraction a bit more. But what does that exactly mean, heart failure with preserved ejection fraction, and which therapy can we even use in this growing patient population? In this slide, you can appreciate a diagnostic algorithm from the ESC guidelines of 2021 of heart failure for the diagnostic of heart failure. And if we go down this algorithm, we see that echocardiography plays an important role. And if you find abnormal findings, you can distinguish which phenotype of heart failure is present by means of left ventricular ejection fraction. And we have three phenotypes. The first phenotype is the heart failure with reduced ejection fraction. That's everything below or 40%. We have the heart failure with mid-range ejection fraction. That's 41 to 49%. And the heart failure with preserved ejection fraction, which is above or 50%. In echocardiography and ejection fraction, we talk a little bit in different means of grading ejection fraction. So first of all, there is a severely reduced ejection fraction, which would be below 30%, a moderately reduced ejection fraction, which still would fall under the definition of heart failure with reduced ejection fraction. It is 30 to 39%, the mildly reduced ejection fraction, which is 40 to 49%, which would probably equal the mildly reduced ejection fraction, and we have a normal ejection fraction, so above or 50%. Now we know that the therapy for heart failure with reduced ejection fraction has new treatment options. Not too long ago, the ARNIs were introduced, the neprilysin inhibitor combined with an angiotensin receptor blocker, and we have those pillars of optimal medical heart failure treatment, the beta blockers, the mineralocorticoid receptor antagonists, the ARNIs, and you have to give the maximal possible dose to your patient. But there's one more class of heart failure therapy. It's making our hearts or the hearts of our patients even happier. It's this specific substance. You can see it over here. Probably you all know it's the so-called SGLT2 inhibitor. So those are the four pillars of optimal therapy in heart failure with reduced ejection fraction. And you see that the ARNIs, the SGLT2 inhibitors, they are relatively new. Now, what about diastolic dysfunction and heart failure with preserved ejection fraction? Well, very long we didn't know what to give those patients. We could have given the mineralocorticoid receptor antagonists, which did help, but we were not sure in regards of the data if it really was an optimal treatment. But there were some new developments in heart failure with preserved ejection fraction. And why is this so important? Why do we need treatment for heart failure with preserved ejection fraction? Because our population is aging. Because we are aging, our hearts become small and stiff. Think about hypertensive heart disease, diabetes, also about several cardiomyopathies where heart failure, also with preserved ejection fraction, plays an important role, and diastolic function as well. In patients with heart failure with preserved ejection fraction, their hospitalizations, their mortality, the 1-year mortality and even the 5-year mortality, they are very high. And basically the only thing we could do was diuretic therapy for symptom control, so against the dyspnea. So the prognosis overall was bad. Then there was the Emperor Preserved study from 2021, which introduced the SGLT2 blockers to the treatment of heart failure with preserved ejection fraction. Let us summarize what these SGLT2 inhibitors actually do. They work at the proximal tubule of the kidney. We have the natrium and glucose co-transporters, so it causes glucosuria if we block this SGLT2. Overall, the SGLT2 blockers were introduced as a therapy for diabetes, and they reduce the blood glucose levels. They work independent of insulin. Now they also have standing in diabetes mellitus type 1, so not only type 2. They rarely cause hypoglycemia because of the still existing SGLT1. So if there's an SGLT2 transporter, there has to be an SGLT1 transporter. It also lowers the blood pressure, but this is a minor effect of the SGLT2 blockers. But what is very important and has to be noted is they are really great in protecting the kidney, so it's a nephroprotective substance, and is also a cardioprotective substance. There are some side effects. You need to tell your patients that they notice that the genital infections, the urinary tract infections, and hypotension. A severe side effect could be ketoacidosis, so in patients with a reduced renal functions, be aware of this complication. If you continue with the optimal medical therapy of heart failure, in heart failure with mildly reduced ejection fraction, you also can try one of those substances to assist the patient and to reduce the symptoms and improve mortality, so the outcomes of the patients. It's the same 4 pillars: the ARNI, the SGLT2 inhibitor, the MRAs, and the beta blockers. But for the heart failure with preserved ejection fraction, we only have 1 pillar so far. The SGLT2 inhibitors do also help patients with heart failure with preserved ejection fraction, so it reduces mortality and is also nephroprotective. To not miss any substance, let's talk about what else is there for heart failure treatment in patients with reduced ejection fraction. Well, there's ivermectin, which is used if you have a sinus rhythm, even though you have a fully dosed beta blocker and you have a sinus rhythm, a heart rate of above 70 per minute, an ejection fraction of below 35%, so we are in the region where the heart failure of reduced ejection fraction is taking place, or if you have a contraindication against beta blockers. The loop diuretics are for the treatment of fluid overload in heart failure patients with reduced, mildly reduced, or preserved ejection fraction. There is also a relatively new kid on the block. It's the substance vericiguat. It's used in the New York Heart Association class 2 to 4. If there is the worsening, so dyspneic patients with optimal medical therapy in heart failure with reduced ejection fraction. You also have to think about the CRTD systems in heart failure with reduced ejection fraction with a left bundle branch block above or 150 milliseconds. Think about the ICD in non and especially in ischemic cause of heart failure with reduced ejection fraction in case there is no left bundle branch block present. In patients with heart failure with reduced ejection fraction, it's also important to think about iron deficiency. And what else can we do for those patients? We can send them to exercise rehabilitation. The multi-professional disease management is very important. And in younger patients, it's also important to think about heart transplantation. To summarize the SGLT2 inhibitors, to also summarize this lecture, if diabetes, yes or no in cardiology, it doesn't matter for the heart. It's an optimal treatment for heart failure with reduced ejection fraction. It is also working for heart failure in preserved ejection fraction. And what these SGLT2 inhibitors did show us is that tinkling sugar can be pretty cool. The patients included in the studies for the SGLT2 inhibitors were truly not healthy. So they were really sick patients, heart failure with reduced ejection fraction and heart failure with mildly reduced and preserved ejection fraction. What do they actually do for our patients? They reduce the hospitalizations for heart failure. They reduce the cardiovascular death and the hospitalization in HFmREF and heart failure with preserved ejection fraction. They are nephroprotective. This is an important effect of those SGLT2 inhibitors that I want to really point out. And this is important for diastolic dysfunction as well. This is the first and so far the only medication we can give and where we have data that they help for heart failure with preserved ejection fraction.